So my name's Kristina Brumme. I actually just moved here to Colorado. I finished my fellowship in San Diego and just started September 1st here in Colorado. So this is a brand new system to me. But I am going to go over tips and tricks to pediatric respiratory distress. There are some videos here that were both from a lot of the transport that I did with San Diego Fire, as well as REACH down in San Diego. And then Joelle D'Onofrio-Oudman, who is the Rady EMS medical director, as well as the medical director for San Diego Fire, helped with some of the content. For this, I actually use Poll Everywhere. So if you guys have your phones near you, if you're not using it, or if you want to do it on your computer, if you want to text 22333 and then Kristina Brumme 286. This will help. There are a couple of participatory slides. It's all anonymous. I use it for a lot of presentations because I actually think it's just useful for you to see what your colleagues are thinking. And also just know that there's a lot of variability about how people think about different situations. So I'll give people a minute just to text and do that. It is voluntary, so if you don't want to, that's fine too. So then this is the first one. So once you have logged in, if you want to start responding with A, B, C, or D, and it's how do you feel about pediatric respiratory distress? We'll give like 10 more seconds for people to respond. I definitely had to modify that particular question because in San Diego, I was thinking about surfing, which was considerably more consistent amongst people. Perfect. So then.
We had a couple comments come in on the chat line, and the best one is just drive fast and pray.
Yeah, that's a pretty normal response, I would say. Great. And I do use videos of actual patients in this presentation, and parental consent was, as well as if the kids were old enough, we got child assent and no children were harmed. I think the video, the audio does not work particularly well through the Zoom platform, but it's more about looking at what you're seeing in front of you, and I can give you, if there's specific questions about what you're hearing on auscultation, I can give you details about that. Okay, so the learning objectives for this particular presentation is just doing a review of the pediatric assessment triangle, which is something that most people are familiar with, looking at airway basics with differences between pediatric and adult airways, troubleshooting some common airway issues, and then towards the end, I will do a case or video review. In all cases, I do encourage you to apply the pediatric assessment triangle just for the sake of consistency. And that also helps in terms of when you're doing your handoff into the emergency department. It's just a common language that we all can use. And basics in pediatric airway. Kids actually comprise about 13. It's depending on the state that you're in, it's anywhere from 13 to 20% of all EMS runs. And if you break it down by age, in the less than 1 year, it's about a third of those runs are respiratory distress. As you get a little bit older, it consistently sort of skews a little bit towards trauma, but at least in the infants, which are often most concerningly the most different from adult patients that you're seeing, it's about a third of your runs. So in all cases, when you're approaching a pediatric patient, you're obviously going to stabilize, look at scene safety, try to identify the problem, and then try to figure out pretty straightforward ways to solve and improve the problem within your own scope of practice. And with the pediatric assessment triangle, one of the beauties of it is you really only need your eyes to do it. That was part of the point, recognizing the differences in terms of how people approach patients when they are in the field. So when you're looking at the appearance, you're looking at the tone, how interactive the child is. If it's an infant or even a young child, are they consolable? Are they looking around regarding sort of the very interactive scene? Are they crying? Are they trying to talk? When you're assessing breathing, you can listen to whatever airway sounds they're making. Are you hearing stridor? Are they holding their head in a position of comfort? Are you seeing retractions even before you lift their shirt? Are they gasping for air? And then with circulation, what does their skin color look like? This does require an element of exposure. So are you seeing pallor? Are you seeing mottling? And cyanosis. Obviously with circulation, when you're looking at skin appearance, you have to be mindful of if you are picking up a child off the side of the road in the Colorado winter, obviously they might look a little bit different than if you were in a sunny desert situation. And when you're really only involving things on the breathing side, that's when we're thinking about respiratory distress. When you recruit a secondary process with appearance, that there's something different about any of those things, that's when you're starting to get concerned about possible imminent respiratory failure. And then by the time you're seeing all three, this is when you're concerned about a life-threatening event or an imminent, it could be a respiratory arrest or something along those lines. And it's always going to be going back to the basics. You're going to be doing the ABCDEs. Is their airway patent? How are they positioned? Do you need to apply BVM? What are you hearing when you listen to their lung sounds? Are they hypoxic? Can you easily just throw on oxygen and solve that problem? Are you getting both a good strong heart rate as well as central pulses? Are you worried about the direction that their heart rate is doing? Do you think it is too slow for their age? And using AVPU to assess their mental status and what their disability is, checking a point of care blood sugar is obviously often very important for children. And then always expose the kid. This is details of if you were to do weight-based respiratory rates, heart rates, and blood pressures, which I do not do well with memorizing tables. So bottom line is kids breathe faster, they have higher heart rates, and they generally have lower blood pressures. These particular features of children can also be exacerbated by, are they febrile? Are they tachypnic because they are 39 degrees when you check them? Or is it actually truly a respiratory process that's contributing to the fact that they're breathing faster? And another question. So if you can select the answer that is incorrect about the pediatric airway, and I apologize, the A, B, C, D, E, just D is up there. So you have a couple options. Smaller resistance, more resistance to flow. Young children are obligate mouth breathers, more soft tissue in the nose and mouth, and a limited ability to recruit larger muscle groups. So looks like most people are responding with young children are obligate mouth breathers. And that is the part that is incorrect. They do have a smaller airway, so there will be more resistance to flow. This was one of those sneaky questions where you're actually being asked the wrong answer. And again, just to remind you, when we're going through this, it's still always going to be to stabilize, look for the problem, and solve and improve the problem. So then when we're looking at the airway, this is just subdivided between the upper respiratory tract, lower respiratory tract. And we can divide some of the pediatric presentations by upper or lower. When we're thinking upper respiratory, we might be thinking croup, a foreign body aspiration, epiglottitis, although epiglottitis used to be pretty much rarer once immunization happened, but we're actually seeing a recurrence of both strep and staph epiglottitis in patients that actually you wouldn't expect it to be. There's a big peak happening in adolescent patients, so it's just something to keep in the back of your mind. Then when you're thinking about lower airway, that's when we're getting into pneumonia, asthma, bronchiolitis. Obviously, the age distribution between those things is a little bit different. And then things that kind of ride the border of the line can be anaphylaxis or bronchiolitis, because you can hear sort of signs of upper airway restriction in an anaphylactic patient just as you're hearing wheezing, which we typically categorize sort of as a lower airway problem. And if you were to guess who would show you their respiratory distress better, do you think by age? Is it going to be infants? Is it going to be toddlers, school-age children, or adolescents? I'll give like 10 more seconds for people to respond. And perfect. This is one of the reasons why I really like Poll Everywhere, because as you can see, there's actually a pretty broad range of questions. In general, it's actually infants will show you their respiratory distress, especially when you fully expose them, just because they don't have the same big muscle groups that you start developing as you get into toddler school age. They will recruit and belly breathe. They'll show you their retractions because they haven't had time to deposit a layer of fat over those intercostal muscles. The patients that actually make me the most nervous are adolescent patients, especially adolescent patients with really poorly controlled asthma, because they're fine until they're not, and you often won't even notice it. So then if you were to identify the problem with these two patients that you are transporting, and I'm gonna ask for some help with if you want to type it into the chat, what do you see as a potential problem here? If they were not saturating well and you're just looking at these pictures, what is wrong with one of these pictures?
Yeah, some people are making comments about positioning.
Mm-hmm. Perfect.
And access to the airway, and then the pacifier as well, people are noted.
Yeah, and we can talk about the pacifier a little bit, but definitely the position. If you, especially with the younger children, we run into that very large occiput. So if you have them lying directly flat, they'll just naturally be flexing their head and kinking their own airway. In some cases, the pacifier is not necessarily a problem, because if it is keeping the child calm, and if they have stridor, or sort of an element where you're trying to recruit laminar flow, you might actually want to comfort them or keep them in a position of comfort. I agree though, car seat makes it particularly challenging. If that kid was to start to be in distress, that would be a difficult thing to navigate around the back of a rig. So then the EMS solution here is something that is covered sort of from BLS all the way up. And does anyone, the particular position that they're putting this infant in, although this is not a great example because of the finger placement, if you want to throw that in the chat too.
Sniffing.
Perfect. And sniffing position, so you're getting that nice, you're trying to essentially line up the sternum and get that nice smooth straight line, and you're getting it in both cases depending on how you are arranging the patient. The reason why I point out these fingers is just you need to be a little careful with a small infant, because they don't have a lot of soft tissue, and it's easily compressible. That you might actually be working against yourself and kinking your own airway. So the problem here in spectacular form is just that they are very boogery patients and they're obligate nose breathers. This is especially true for younger infants. This is why bronchiolytic patients often will have difficulty with feeding because they can't breathe and coordinate eating and feeding at the same time. But same thing goes up until they're easily coachable in terms of blowing their nose, that sort of thing. So then what would you like to do? I don't know if anyone has put anything in the chat at this point.
A few are rolling in now. There's always a little bit of a delay, but you're getting a bunch of suction and then moisten and then suction. Clear the nose.
Perfect. So there are a couple of suction devices, and then definitely if it is dry and stuck in there, using some normal saline can be really beneficial. If parents do have a nose Frida, generally speaking, that will generate more suction than one of these bulb suckers. It also doesn't have nearly the risk of growing a lot of mysterious things behind the opaque bulb sucker. So that's always something that I recommend. But that is definitely true. And you can both clear the nose as well as do a little bit of suctioning in the back of the posterior pharynx. But obviously you don't want to gag the child. What do you see as a problem here? The dog is mimicking the problem. And then obviously this picture of the child on the right over here, this is not a normal child. I would point out there's pretty significant micrognathia or a very small jawline. Obviously they have something wrong with their feeding based on the tube that they have in place. But any concerns about these particular patients and their airway?
There is not a lot of neck to be seen.
Yeah. It's a combination of sort of big tongue, small neck, because in general, it just makes it super challenging for you to even be able to get suction or anything else. Or if you are getting to the point where you're doing bag valve mask ventilation, are you even going to be able to sort of get a good seal if you don't have a good jaw to be putting on it? There's a number of pediatric syndromes where you might see that micrognathia, and proportionally their tongue and sort of all of the soft tissue in the posterior pharynx will be working against you. So it can all contribute to a possible airway obstruction. And what might you think about as possible ways to solve this problem? And there's a couple.
Yeah, so a lot of comments coming in using like a basic airway, like an NPA or an OPA to just kind of help splint that airway open.
Perfect. And then the one other big thing, and the one that I was looking for, although I definitely agree, those are really good tools, is doing a good jaw thrust. It's harder with the micrognathic patients, but they will have actually a good point of the TMJ. And I hope that this video works, because this is a good example of why a jaw thrust is so important. This is ENT video of, let's see if it's actually gonna, I wonder if this is what made my computer freeze the last time. It's funny because I ran these slides through. At the very least, yeah, it is definitely the videos that is making this problematic. ENT did a series of videos showing exactly how important a jaw thrust is by actually having a flexible scope in the airway as they were watching people do a jaw thrust. So when this presentation goes out, I would just encourage you guys to look at this video, where essentially it shows a totally occluded airway, a big floppy epiglottis in the position, and then as soon as you see the jaw thrust, you actually see a beautiful view sort of straight down the vocal cord, straight through the trachea. So I apologize. I don't know if the videos just don't like how many people are trying to interact with it, or Zoom in general. So just give me a sec while I try to advance my slides again. All right, so solution number 2 was exactly what people said, was using airway adjuncts, either using an OPA or an NPA. And just as a reminder, you're measuring them from the mouth to the angle of the jaw or the nose to ear. Just be mindful of the fact that if these patients are sort of fully conscious fighting you, you might make them throw up on you, especially if you use a slightly improperly sized. I would say we run into that more as a problem with the OPA as opposed to the NPA, just because of sort of how it has to be positioned in the mouth. But it's something to keep in mind. So then here, one of the problems with the airway, when you're looking, there are smaller upper airways, which means there's increased resistance, and this is actually proportional. It's inversely proportional to the radius of the airway, which means if you're looking at this adult trachea sort of further down, even if you have inflammation, sort of some kind of infectious process happening, the resistance is only going up like 2.5 times what it would normally go, as opposed to if you have this little whiff of a trachea in an infant, that resistance is going up 16 times, which is significantly higher. And this has to do with a lot of the anatomic differences in terms of what the epiglottis looks like, what sort of the funneling that happens at the trachea in the subglottic space, how cartilaginous the trachea is itself. Do they have any laryngomalacia or something along those lines? And I'm like a little hesitant to try to play any of these because I feel like they've been really frustrating, but we'll try. And okay. Again, I apologize about the videos. The big thing for this particular patient is this is a patient that sounds like a patient with laryngomalacia. So they have a very floppy airway. Does anyone know an easy way to see if there's an element of laryngomalacia, especially if you have an infant that is like a little bit stridulous, just sort of resting comfortably, doesn't seem to have a whole lot of respiratory distress? How might you test if it is actually sort of a structural airway problem? Any responses in the chat here?
So no ideas.
So the easiest way is actually just to prone the patient, because if you put them on their belly, you are using gravity to stent open the airway. And if you note that basically there's total diminishment of that sort of stridulous, snuffly upper airway sound, that usually tells you that there's an element of laryngomalacia. There's a huge spectrum in terms of what these patients can look like. Some parents are well followed because they were followed in the NICU or they see ENT already. But even sort of younger patients, just by fact of not having the cartilaginous rings, will have an element of this kind of floppy airway. And so proning them is a really easy way to test it out. And here is another example of how the infant trachea is different, because it is actually comparatively, we have this nice smooth sort of rectangle going down the adult subglottic space, as opposed to we have this funneling of the infant trachea, which in some ways also for us when we're thinking about intubation makes it particularly challenging. And in terms of the solution here, a lot of times with this narrowing, the big problem is you can't get smooth laminar flow of that airway. So if you have this angry beast of a child in the back of your rig, they are crying, they are not getting sort of smooth, deep breaths in. The best way is to try to calm them down as best you can. Here you can try to recruit the family. If it's not a patient that's in significant respiratory distress and you feel comfortable having a family member try to soothe them, that sort of thing, depending on who you're transporting at the same time, then you're sort of optimizing how much air can go through that narrowed passage if you can try to keep them calm. That's why with the first picture of the patient who had the pacifier in their mouth, if the pacifier is not making them significantly hypoxic, but is keeping them calm, that's where the trade-off comes in terms of trying to figure out how to do it. And then you can also potentially if you are still getting stridor, you're still not improving that laminar flow, it's an older patient, you're trying to get them to talk, this is where we think about using inhaled epinephrine or racemic epinephrine if it is truly stridor and respiratory distress. And it is stridor at rest that we treat. If it is a child who is really angry and really pissed off and is crying consistently and is stridulous, it is not necessarily going to help you out a whole lot. It's more for the stridor at rest. And this is you're using the nebulized epinephrine. We have the luxury of sort of the prepackaged racemic epi in the emergency department. Here, if you saw this child in front of you, what might you give them?
A few epis coming in.
Okay. And the big concern here that I have for this particular patient is angioedema, that they have significant swelling of their lips. Are you going to be evolving into a critical airway situation? So I agree, using either subcutaneous IM epinephrine is sort of more frequently given. Subcutaneous epinephrine was a holdover sort of historically that we were using a lot actually in asthmatics and things like that. But this is concerning because anaphylaxis can evolve so quickly. So if you are concerned about it, just give the IM epi. If it's a patient who has a known allergy, you can use their own EpiPen or their own ABQ. And it is the first line treatments. The sooner that you give it, the better. An adjunct that we use in the emergency department is we're giving steroids, potentially dexamethasone, prednisolone, methylprednisolone, depending on what the patient looks like. And then here is another problem. This looks very similar, but the same thing is true for the lower airways. As you get down to the level of the bronchioli, you're still getting into the problem of increased resistance. And what this means is if you do have bronchiolitis, you're going to see worse mucus plugging, and the mucus plugging that happens is going to have a significant impact on their respiratory distress. In patients who have a known history of asthma, this is where albuterol can be helpful, and it will be a bronchodilator. So then whatever constriction in the airway, you're at least giving the benefit. If you are thinking it is bronchiolitis, but it is a child who is an atopic child, they have a significant like eczema rash, the family is reporting both environmental as well as food allergies, this is not necessarily a patient that I would hold off on giving albuterol. And I know that protocols vary depending on sort of the county as well as the state. So obviously I'm not trying to tell you to do something that's not on protocol, but that is something to keep in mind if it is a younger infant and it might be sort of a first-time reactive airway. And here, nebulized versus puffs with an MDI and a spacer actually have been shown to be roughly equivalent. In some cases, people think that the nebulizer is more beneficial, but if you are using a metered dose inhaler appropriately, it actually is roughly equivalent. In some cases, some of the benefit might be from the fact that you're giving them humidified air in addition to the bronchodilator. And so you have a known asthmatic and you've given a duoneb and the wheezing seems better, but they're more hypoxic. Why do you think this happens? Perfect. So it seems like sort of a mix between they might have pneumonia versus VQ mismatch. And it is generally VQ mismatch. Our bodies are quite smart. If they don't feel like we're getting appropriate ventilation from a particular area in the lung, it will just shunt blood flow away to areas that are getting better ventilation. And there is a delay in the response to medications to that. It is still possible that if you've waited, their wheezing is much better, and it's been like 20, 30 minutes after you gave that duodenum and they're still hypoxic, that there might be a secondary issue going on, especially if they're febrile, but generally speaking, it's often VQ mismatch. So this is when we are using potentially ipratropium, and this would be an anticholinergic that's usually used in combination with bronchodilators. And it's for patients with wheezing and retractions. Generally speaking, this is not beneficial for patients who have bronchiolitis. This is just for asthmatics, and all of the studies have supported that. And here you're using the 0.25 to 0.5 milligrams nebulized ipratropium, usually as in combination with your albuterol. In the emergency department, we have a lot of extra tools to help with these patients. We can give magnesium for further bronchodilation. This is for some severe asthmatics, although we're starting to use this earlier and earlier. There are a couple, I think, in Washington State, some of their EMS protocols on the paramedic and the ALS rigs are supporting use of magnesium early. I think Pennsylvania is another state that has looked at it. California did not have it when I was there. And then we also can escalate sort of different modalities of positive pressure, whether or not you're using a high flow nasal cannula, nasal CPAP, BiPAP, that sort of thing. And these are all examples of those patients. And then there's lots of other adjunct medications. In this case, if this is a patient who is brought out of the water, pretty minimal respiratory effort, obviously respiratory failure, what would you like to immediately do to this patient?
Open and clear the airway are a few coming in.
Perfect. And after you've opened and cleared the airway, if they are still making pretty poor respiratory effort, what next?
We have some positive pressure ventilation, positioning.
Perfect. So generally speaking, it's going to be bag valve mask ventilation. And especially with patients who are drowning patients, which this is an example of, this can be life-saving. Children are generally speaking easier to bag compared to adults, but it will definitely be life-saving. And in general, the big tips for BVM are to do a good CDE hold, a good jaw thrust. In my teaching, we're always taught, like, if you can have two hands on the patient and someone else bagging, that is the optimal way to get a seal, which is very convenient for me in the emergency department because I have lots of hands around me. I know that that is an optimistic thought for a lot of people who are out picking up patients. So if you can try to optimize your own, and if you do further education regarding pediatrics, just figuring out how to get your hands positioned well is really important. And like we said before, the big issue with this particular picture is this person's fingers are essentially right underneath their jaw, and while they're trying to get that good jaw thrust as well as holding a seal, you might inadvertently be occluding the airway, especially in the teeny tiny babies. And the number one cause of cardiac arrest in kids is respiratory failure, which is why good bag valve mask ventilation is life-saving. So I'm sort of curious how, and I, again, apologize why these videos are not working particularly well, because most of the cases are case-based, but I can potentially describe. Let me see. We'll try. Yeah, no. Obviously, there's a little bit of a hint in terms of you're seeing a picture of a child who is obviously getting air sort of helicopter transport. So in terms of respiratory distress, you're seeing pretty significant respiratory distress. But this is an asthmatic male who has shortness of breath, is wheezing. I will do my best to do an interpretive description of what the video would show. But again, I encourage you, once this actually goes out, you can play the videos for yourself. And generally speaking, we think of wheezing as primarily a lower airway disease as opposed to an upper airway disease. And If you are asking for more information, this is where the sample history comes in. The patient is having wheezing and shortness of breath. They're allergic to peanuts. The only medications they have are albuterol as well as an EpiPen as needed. Has a history of pretty significant asthma, allergic rhinitis, had an appendectomy. They last ate some cookies 10 minutes ago and started coughing and seemed to have a wheeze. The family, who is actually pretty adept, tried albuterol twice with only minimal improvement. Man. And when you are looking at this patient, hypothetically, if you could watch this video, this patient has a very prolonged expiratory phase, is taking those sort of long, slow exhales out. You're hearing pretty significant wheezing and very significant retractions. Oh, man. Okay. So then as we get to the exam, the airway is patent, they're wheezing bilaterally, you have nice strong pulses, capillary refill is less than 2 seconds, the patient is chatting with you and is alert. And when you expose them, you note this like very vigorous sort of pruritic raised rash that's starting to surface on their trunk. And in this case, this is likely anaphylaxis. And it's one of those things that it's an easy thing to confuse, especially if you have a patient who is wheezing and is a known asthmatic. Everyone's knee-jerk response is to give them albuterol, but a lot of these patients also have concomitant eczema or other features of atopy. This particular finding, when you can actually see this raised, it's often with very light sort of tracing on their skin. It's called dermatographism, and a lot of patients who are sort of allergy triggered will have this particular finding. And anaphylaxis, I took this from sort of the criteria for anaphylaxis. If you're following down, I know this is a busy slide, so I apologize. But if you're starting to see an acute onset of respiratory distress, you're starting to see involvement of the skin or the mucosa, there's evidence of respiratory compromise. There can also be potential GI involvement. This is when you're starting to think more along the lines of anaphylaxis. Obviously, you also want to think about anaphylactic shock and whether or not the patient is hypotensive. And once you've considered sort of the different criteria, and you've sort of optimized their position, you've given them oxygen, that kind of thing, this is when IM epinephrine is going to be life-saving. And if they respond to it, great. Often patients will respond nicely. If they don't and you're seeing persistent wheezing, you can consider whether or not you want to use a bronchodilator. By the time they get to the emergency department, that's when we're thinking about steroids, antihistamines, glucagon, sort of other adjunctive medications. And EpiPens are super helpful. The teaching is that you need to administer it and then hold it for 10 seconds. When they actually did studies mostly related to anesthesiologists injecting their own fingers by mistake, most of the medication is dispersed in the first 3 seconds. But I think not a lot of families and or patients are super comfortable with stabbing their own child in the thigh. So just making sure that they held it and then you can help them out with it. And there have been a number of protocol updates related to how you can treat anaphylaxis. And one of the biggest things was BLS was actually started, at least this was in California, BLS was allowed to give an epinephrine auto-injector, especially if it was a patient's own medication, which was something new. And again, wheezing stridor, you have to think to look at the patient, check their skin, their blood pressure, their perfusion. Are they vomiting and have diarrhea in conjunction? Is there secondary system involvement? So then this patient, obviously sort of given away by having this high flow nasal cannula set up on, is a 12-month-old who is very stridulous, is also looking kind of pale and mottled, is struggling to breathe. You have significant respiratory distress. I'm not even going to bother trying to play the video here. And here we're actually concerned about respiratory failure because this patient has multiple areas of the pediatric assessment triangle involved. And when you're thinking of stridor, this is more of an upper airway problem. And the solution, if you are trying to decide if there's upper airway involvement, what might you be listening out for? This might be different depending on the age of the patient. If you're seeing a toddler or an infant versus an older child, and there are actually multiple correct answers here. Perfect. So these are actually all correct. Stridor at rest is sort of the big one that we think about when we think about croup. If there is a change in the voice, drooling, increased secretions, that you might be considering like an aspirated foreign body. If they have a barky cough, that also is suggestive of croup. A lot of families have seen multiple episodes of croup, so can kind of identify it and help you. And this is your sample history for that 12-month-old. They have that barky cough, runny nose, fever, and stridor. They're allergic to penicillin. They just have reflux, so they're getting ranitidine. They are developmentally delayed. They have a G-tube. They have a history of laryngomalacia. Just had Pedialyte. G-tube feeds went just fine 3 hours ago. And just has had this recent cold, barky cough, fever, and seemed to get worse at night. And that description is very common. And the worsening at night often is related to the fact that when patients lie flat and they sort of have relaxation of all of the soft tissue structures in their throat, or some element of postnasal drip, it can often get worse. So the airway is patent, but you're hearing stridor. It's both inspiratory as well as expiratory. Their cap refill is less than 2 seconds. They seem a little lethargic, like they're not that mad when you try to suction them, and they don't have a rash. So here, I would be concerned with respiratory failure with stridor, and you would consider croup. Other things to consider, especially in a young patient who has some other medical complexities, and I think actually Michelle's lecture will talk a little bit about various things related to not wheezing, but do they have epiglottitis? Have they narrowed their airway? As I said, epiglottitis is making a little bit of a resurgence because of community acquired as opposed to being related to H influenza after we were able to vaccinate. Do they have a vascular ring or something structurally unusual about their airway? Did they aspirate something? Did an older toddler in the house give something to the infant? Do they have other sort of vocal cord papillomas? And then with patients who have floppy larynx and sort of laryngomalacia, any whiff of respiratory distress will sound much more spectacular for them. And with croup, it is generally speaking upper airway, and within the trachea itself, you're starting to get an inflammatory process and some narrowing, which we can often see on X-ray eventually. Historically, the big thing that we saw was actually diphtheria, and there was a lot of advertising of like, thank goodness we have a vaccination. And this, we were seeing these pretty horrible plaques. And it's common for like refugee patients or patients coming from particular areas in the world. It's still actually endemic in sub-Saharan Africa. So if it is a patient who recently moved, it's a thought to keep in mind, but it will sound and look pretty similar. So viral croup is sort of the modern day croup that we see most frequently. And then it responds to racemic epinephrine and steroids. Bacterial croup is bacterial tracheitis. And these patients generally look a lot sicker. They might not respond to your epinephrine. They sort of might still be struggling to breathe. And this would be a thought when we're starting to look at whether or not we have missed something in particular. And then racemic epi, steroids, potentially antibiotics and IV hydration, heliox and intubation are all things that we're thinking about in the emergency department. But the bottom line is epi can be life-saving, and nebulized epi, giving it a try. Even in stridulous patients who you have given nebulized epinephrine, you can consider doing an EpiPen as well. I've had that be very successful. in the field. And I'm not even gonna, I don't know that we can make it through this.
I'll second that. I've also had success with an EpiPen in a kid with a closing airway with Croup.
Right. Okay. The big thing for this particular patient is you need to remember to expose the patient entirely before you're trying to make your assessment. And if I can advance my slide, I would. But here you're seeing an infant who is having respiratory distress. It is a 2-month-old who had a little bit of a pause in their breathing, but has also had some significant nasal congestion and rhinorrhea. And they've just been, the parents are describing really, really snotty, and they're in respiratory distress. They have some retractions, they're doing some belly breathing. And in general, when we think about sort of the snotty bronchiolitic type patient, this is where you're getting into kind of that mixed upper and lower. And generally speaking, people do classify bronchiolitis as a lower airway problem. And this would be where on exam, again, I'm so sorry about the technical difficulties. On your exam, you are seeing just boogers galore. Their airway's patent. They have some retractions. They have strong pulses. They seem to be sort of smiley and happily tachypnic, and they don't have a rash. And this is when we're thinking about bronchiolitis. So then, if your patient has bronchiolitis, what do you want to do? And this again is a question that has a couple of different answers. Perfect. And if they are hypoxic, for sure, giving them supplemental oxygen is super helpful. I would probably try clearing their nose before administering that, and then it might actually be more successful in delivering. If they are a patient that potentially has sort of history of allergies or atopy, you can consider trialing a DuoNeb if after you suction you're not seeing an appropriate response. Obviously, driving faster but safely to the emergency department is always an option. And then bronchiolitis treatment, there's been a lot of studies about what should we be doing. Suctioning, supplemental oxygen if they're less than 90, nebulized saline, 3% saline has also been used. But there's actually, when we look at the other things like albuterol or steroids, there's actually a ton of studies that have been directed related to bronchiolitis. And essentially, other than suction and supplemental oxygen, really nothing else is data-driven. So it's not really a tool. But obviously, if you're trying to manage respiratory distress in the field and you feel like you want to give a try, do close reassessment, that is also appropriate. And so I think because of the time, I will just skip forward to, if anyone has any questions, I'm happy to take any questions. As I said, I very much apologize for the technical difficulty.